Well, all right, everyone. Welcome back to the Dr. Alex Show. And I have a cool guest in studio today. And as the reminder to everyone, our studio is technically not a studio. It is the old post office's vault. We are locked in a vault right now, which is a little unnerving at times. But as long as the door continues to work and no one locks us inside, we're okay. Anyway, today I have in studio a guest, Dr. Jake Kneeman, and I met him back in January, I think so. And he is a local pain specialist here in Lee Summit and on the Kansas side in Overland Park. Do I have that right?
Yep.
Okay. And I'm going to have him tell more about himself in a sec, but got to meet him because we had a little lunch and learn about the latest in technologies with pain management. And one thing that we do at HML is not only do we like to work with kids with special needs and just an array of issues, but one of the problems that a lot of these adults have is and parents have is they're in pain. And we do pretty decent with chronic pain, but the thing with chronic pain is it comes from a host of issues. And with these issues, we have to apply more technologies. And when we get up against the wall with our patients, then nowadays I'm sending them over to him uh, because of just some of the great minimally invasive options that I know I didn't know were available. I mean, I was blown away. I was like, this is really cool stuff because we certainly didn't learn about it in school. So anyway, I'm going to hand it off to you, sir. Why don't you just tell everyone a little about yourself, how long you've been around, been in school, or how long you've been out of school, everything else that goes into being a pain management doc. Let's just start there.
Sure thing. And thanks again for having me on the show, Alex. I really think it's going to be a great opportunity for us to continue to collaborate in the future. So I'm Jake Kneeman, originally from Tucson, Arizona, born and raised. And then throughout my training, I've been in several cities, including Chicago, Boston, Seattle. Trained actually in physical medicine and rehabilitation for residency. I was really focused on quality of life and function. And then pain medicine kind of grabbed my attention because I liked using my hands and doing minimally invasive procedures, and I could still focus on quality of life and function by using these skills. So that's kind of what led me down that route. I graduated from fellowship in 21 and have been in practice at Kansas Pain Management since then. So I've been at my same practice. Everything's going really well, and we opened up a branch in Lee Summit recently, and so I've been trying to build that, and and so that's kind of where I am now.
And it's Kansas Pain Management, correct?
Yes, it's Kansas Pain Management, but majority of our offices are in state of Kansas, but our only location so far in Missouri is Lee Summit at the Lee Summit Medical Center.
Well, and it was long overdue for someone to come over here because is there even anyone else doing pain management in Lee Summit that you guys know of?
Yeah, there are a couple groups, but they've been there's really can KC Pain has been the one historically there for a while, and then there are a couple other new folks on the block, but really that was it. So I'd say our venture over is definitely offered some easier availability and quick access to care since coming over. So a lot of the patients I see actually would tell me that they would need to wait for anywhere between 3 and 4 months to be seen by someone, whereas I can get someone in a week.
Yeah. I I wonder if that's why I question like why, were there even was there even another group? Because everyone I know that has to go to pain management up until I met you, people would go see the primary would send them somewhere off in Kansas. It'd never be over here, and I guess that explains why, because they were already just backlogged.
Exactly. Yeah. And so that's where we try and pride ourselves is to gain give patients access very, very quickly. And so typically, like I said, a week max. And if they're looking for sooner, we can actually sometimes get folks within 48 hours to be seen, although they might need to drive to the Kansas side. But um, yeah.
Sweet. Okay, so now something that I think we got to distinguish real quick, and I think this is where this conversation is going to go is what would be the main difference between what you do, what you guys do, maybe sports med, and even what the primary has to offer for pain?
Yeah, these are great questions, and to be honest, the answer will vary regionally depending on where you're in the country.
Ew.
So here in the Midwest, typically what I've seen, and again, I've only been living in Kansas City since July of 2021. So what I have learned based on my own experience so far has been primary care physicians are the ones mainly prescribing medications. So anti-inflammatories, opioid medications, um, nerve pain medications, or anti-epileptics. Sports medicine folks are typically seeing more acute injuries associated with joint pains. Sometimes they do see acute low back pain, acute neck pain, but they'll see a lot more acute issues, and then they see soft tissue issues such as tendons, a lot of arthritis, which is kind of where we overlap with sports medicine. Um, and so, pain, then the pain specialists primarily in the area, we do minimally invasive interventions for joints as well as the spine, but that they're kind of beyond. Well, for the back primarily, the one thing you'll hear is epidural steroid injections. That's kind of the, I guess, buzzword for the pain doctor in general, but that's changed quite a bit. Now, there's a lot more that we can offer than just epidural steroid injections these days. So that's where I'm really excited about is, and that's where we connected was over that the newer technologies that are in the space, um, and that's what I'm most passionate about. And so it's a good time to be in the field.
Awesome. So, just speaking of injections, real quick, I know I had met at least he said he was a pain management guy, and he did steroid injections, prolotherapy, and a couple other concoctions. Do you guys have things like that over there?
Yeah. Yes. So we do. Yes, we can do prolotherapy. We can do stem cell injections. The only issue I raise with those is that it's all out of pocket, and so sometimes patients just won't be able to afford that because insurance doesn't cover it. But no, we can certainly do it. We have the same skills. Um, it just instead of a steroid, we just have a different solution in the syringe, right? But it's the same skill. We still use ultrasound or an X-ray to guide the actual procedure itself. So no, it's really no different, just different solution.
Cool. Now, I guess just to clarify, because some people are thinking like, okay, they're going to go in and they're going to get an injection. You just said something that was really neat. The fact that you'll use imaging as you're injecting the spine or the back or something, correct? Joint.
Absolutely, absolutely. That's actually now standard of care in our field is actually this maybe 30 years ago, 40 years ago, pain doctors would just come in and inject people's necks or backs without any kind of guidance, which sounds terrifying to me.
Absolutely.
Yeah, but now, no, absolutely. X-ray is kind of the standard of care for guidance if you're doing any kind of injection in the spine. Um, if you're talking about the joints, that's where it's really practitioner dependent. One person may prefer ultrasound, whereas the other may prefer X-ray. But we know, and we've demonstrated in the evidence, there are studies looking at the efficacy of guided versus non-guided injections, and guided have been shown much more superior to non-guided. So nowadays, if someone is trying to stick a needle into your neck or back and doesn't want to use a X-ray machine and other than a trigger point injection, then I would maybe get a second opinion somewhere else.
Yeah. Yeah. When you're going into joints or somewhere close to that spinal cord, yeah, because that patients will be skittish about that. If I'm like, "Hey, we are tapped out," and for good reason, they're like, they're gonna take a needle how long and do it?" And I'm like, "Yes, but it is guided with imaging. They're watching where they're going with what,"
Exactly.
and
Yes.
it's and as ridiculous as it sounds, I mean, people drive, trains that are 3 miles long for crying out loud, and they're like, "It's not a big deal." It's really not that big of a deal when you do it enough. Taking needles, guiding in, because you get good at what you do.
Yeah, and we do use plenty of numbing medicine. So, majority of my patients who I talk to about injections, I tell them that the worst part usually is the numbing process.
Hmm.
So the numbing is just an anesthetic medicine that I use to anesthetize the skin and tissue underneath the skin, and that is a little bit uncomfortable. Feels like a sting and a burn, but then everything goes numb after that, and I really only feel a little bit of pressure after that. So after that initial sting and burn, usually patients are pretty comfortable.
And then after that, follow-up question for everyone with thoughts in their mind is, what happens after that? Do I get to go home?
Yeah, great question. So yeah, majority of the time patients walk. I'd say 99%. I can't remember last time nobody walked out after a procedure. Yes, so most of my procedures, patients come without a driver. They haven't, they've taken off work maybe just for that one injection, but they go back to work right afterward. Really, my only restrictions are regarding soaking the area in water or applying a heating pad for 24 to 48 hours. But otherwise, there's usually a band aid or two on there. They can take that off when they get home. They can shower right away. There's, yeah, and otherwise, no real restrictions.
And now, does that include also being able to perform other therapies?
Correct. Yes. Yes. So oftentimes, I will have patients who are not just seeing me, but a chiropractor or a physical therapist or somebody else, and I always encourage them that this is part of their care. So um, typically, I do not tell folks to avoid any other care for their symptoms in the meantime. In fact, I usually think of the care as synergistic. Now, I don't have evidence to support that to demonstrate, but I do think that as long as they're getting symptomatic relief, that it's just one adjunct of their entire treatment.
Yeah. And I'm right there with you. I don't know if there is evidence, and I love research, but as far as this goes, I don't recall anything in school. What I do recall is in postgraduate studies, they said they didn't even tell us this in school. Like, hey, you can go and your patient can go and get a pain injection, a steroid shot, and get something done where they're in and out that day, and then get back to activities right away, including seeing you. I learned in postgraduate studies that docs were like, yeah, go send them off. And then what's going to happen is if it's steroid or if it's prolo or if it's some other what I call concoction or a cocktail to help those tissues deflame or regenerate in
Hmm.
certain fashion stem cell, uh, they said, have at it. It's going to help you get your work done. Because if we're in there and we're adjusting the spine or we're working on soft tissues and we were up against a wall and now those tissues are in a much different spot. It always helps.
Hmm. Yeah.
And
No.
and that's all anecdotal, but it every
Yeah.
single time they come back from seeing a practitioner like yourself, we can get more work done.
Well, that's great. Well, that's great to hear. Yeah. I don't think I've ever told someone not to or to avoid a certain activity other than the soaking and heating restrictions, and that's just to keep the skin nice and healthy while they heal for the next day or two. But
Yeah.
other than that, yeah, how about it?
Awesome. Okay, now let's go into the cool stuff. So some of the technology that you showed me, maybe the best way to do this would be scenario. And I can think of a few scenarios like everything else in our office, it comes in waves. And the last 4 weeks, it's been waves of disc issues. We've had cervical spine issues, we've had lumbar spine issues, we've had really bad herniations, lots of plenty of bulges come in after seeing them on imaging, desiccations, uh, full blown sciatica, just down to that big toe, awful stuff. And we can only get so far with these people at times, at least in our office. And we're throwing everything at them. Our electrical stimulation, we're adjusting. We have our fancy flexion distraction table that takes pressure off the disc. We're lasering with our shed light cold lasers. Sorry, Dr. Griswold, I forgot to bring my laser today. Uh, but that's a really good example of we use those lasers for everything. We will put those lasers on those discs for 30 minutes at a time as the patient's laying there, and it will help. anesthetize the area and deflame it. And it'll get the patient so far, but man, if it's lit to the gills, we're only going to get so far. So big shout out to Shed Light Cold Lasers. And when we send them off to you, let's say they're herniated, they're bulged out. What are some of those awesome therapies that you had shown me the other day?
Yeah. So let's start with the basics. So usually the first thing that I typically recommend is, well, we've mentioned it before, but an epidural steroid injection. Typically, how I practice is I want to try the least invasive, lowest risk treatment option first, and then if that doesn't provide or doesn't help us reach our goal, then we can kind of escalate the care from there. So, really, the first would be an epidural steroid injection. The whole idea is that, as you mentioned, there's inflammation in the area, and we need to do something to reduce the inflammation that hasn't responded to adjustments, cold laser therapy, anti-inflammatories, steroids, oral steroids specifically. And one thing I can do is literally put a little bit of steroid right around the area that's inflamed. And usually that's the location, how I'd choose where to put it is based on imaging findings as well as where their symptoms are. So I use the combination of those two to understand where do I need to actually deliver the steroid in order to have the most effect. So that's usually what I start with. Now, sometimes one injection is insufficient. So sometimes the patient may need two, sometimes three, just depending on how they respond. So I never sign anybody up for um, a series automatically. I always just say, let's just try one, see how you do, come back, and depending on where you're at, we'll go from there and make our next decision. So that's really kind of the first thing I'll try. And that's not new. That's been around for many years, but um like I was saying earlier, all image guided. So in this case, it's usually using an X-ray.
That's awesome. And real quick, on the note of shots, it seems like the public has caught up with just I'm not sure if it was just not good care or if we just didn't know better, but people would get quite a bit of steroid injections and they end up having immune system issues, things like that. Is there any concern with, at what point is there a concern for having too many, let's say, steroid injections?
Yeah, actually, I do talk to patients about this pretty regularly. So I usually limit the total number in a 12-month period to four. The reason for that is that usually, if we expose the body to too much steroid, you increase the risk of reducing bone mineral density. You can alter the hypothalamic pituitary adrenal axis. Um, you can temporarily increase blood glucose levels. So there are consequences to exposing the system to steroid, even though this is a very localized input of steroid. It still can be absorbed in the body to a certain extent. And so I usually tell patients that I'm hoping to get you multiple months of improvement. But if I've done my third epidural steroid injection within a 6-month period and we're not making any progress, then usually by that point we have to change the plan
Got it.
because I don't think more steroid injections is the answer.
Yeah. And that speaks volumes to this audience because if people are listening to a show like ours and and patients are coming into offices like ours, they want to be conservative. Um, I kind of picked up on it more after COVID. I think people got a little more conservative with their healthcare after COVID for some whatever reason.
Mhm.
And whether that's controversial or not, we don't need to go there. It's just something I've noticed. So that's always a concern. Like, okay, doc, what if they're just gonna sign me up for rounds of
Yeah.
injections or all this stuff? And I'm like,
Yeah.
it's not really like that anymore.
Well, I actually see a lot of new patients in Lee Summit who come from previous pain doctors who give me that same exact story is, well, I had the series of injections and it didn't work for me. I will say that there's no evidence for that series. It is entirely anecdotal from experience of previous pain physicians that piggybacking on the effect of the steroid each time somehow got them a more significant pain relief effect. I I've seen it maybe once or twice, but again, I that's not how I make my decisions. I usually, if that's not an evidence supported decision, so I just don't operate that way. I usually just say we're going to do our best with really one or two, and then depending on how you're doing, we'll kind of come up with a new plan. Um, so
Got it. So now let's just say patient A came in, they got maybe a series of shots, they went back to their chiro, went back to PT, life's great. Let's go to patient B. Same, let's just say twin sister, same situation, did not respond well to anything you did. What's next after that that you got in store for
yeah,
them?
great question. So at this point, I want to clarify what the exact diagnosis and symptoms are. So if we're thinking radicular pain or sciatica, the colloquial term, then I always evaluate, is your pain exactly the same? Is it still, are you still having the leg pain, or is it just back pain now? So that's the biggest question that you have to ask first, because I have a lot of patients who will come in after epidural steroid injections, and my ancillary staff has roomed them and got their pain score, and they hand me the sheet and it says 8 out of 10 having back pain, right? And so then I'll go back into our initial note and review what I documented as where the location of the symptoms were. And then I'll go back into the room and I'll say, "Hey, so how are your symptoms?" Kind of ask an open-ended question first and see what they say. And then the difference is really what I'm paying attention to is, are they still complaining of leg pains, or is it just back pain?
Sure.
Because oftentimes the radicular or sciatic component will have resolved, but they're still having back pain specifically, like kind of near L4, L5, S1 region. But they say, yeah, no, I'm not having the leg pain anymore. It doesn't go down my leg anymore,
Yeah.
but I'm still having low back pain. So in that respect, then I think, okay, well, actually, the epidural steroid injection did do something. It took care of your leg pains, but maybe we have a different cause of your low back pain. And at that point, that's when I start thinking of different treatment options. So the next one typically that I'll go to is something called a medial branch block radiofrequency ablation treatment. Basically, what this is it's still through needles, and basically, essentially, I use a diagnostic injection to figure out whether someone's back pain is coming from the facet joints in the low back. Um, the facet joints are innervated in a particular way, but basically I can numb them up temporarily just to see if their pain goes away temporarily. And if it does, then they can come back for a procedure in which it's the ablation. So basically, radio frequency energy is passed through a probe and basically heats the tip of a needle to about 80 degrees centigrade. And I literally just put that tip of the needle right next to the nerve, and it cauterizes the nerve. That can provide back pain improvement anywhere between 6 months to 2 to 3 years.
Jeez.
So that's actually pretty nice, but we have to find the right person who has that type of back pain. So
Sure.
you have to find the right candidate for that. It's not for everybody, which is why we do those diagnostic blocks first, because we found that, and this has been shown in studies, that if you just ablate everybody, you skip the diagnostic part, then a lot of those patients don't improve.
Sure.
So, so we do go through a little bit of a funneling process to find the right candidate for that.
And that's ah, and people love that. I think that's kind of why they like what we do so much. Because let's say someone's not able to balance so well. Well, I'm going to stimulate the brain in a way to change that balance. It'll change right there in office. I don't have to wait for a medication to kick in for a few days or a week, right? But it's gonna figure out like a trial, like a therapeutic trial,
Mhm.
and it gives them the idea of like, yep, okay, I and people can understand and put up with that and get way more on board with that than just, oh, we're just gonna ablate it to ablate
Right.
it.
Right.
And I mean, you're talking to a super ultra conservative medical based guy. Like these procedures are not meant to be done right away. Like you said, you want to go conservative
Correct.
first.
Absolutely. Absolutely.
Go see all your therapists, all your
Yes.
ists first, and then start
Yes.
getting your injections. And then going in and going into like a facet joint ablation. That facet joint, by the way, people, that's just the joint that allows motion from one bone to the next. So
Yep.
it's how L4 connects to L5 to S1 to every other bone in the spine. And if you look at pain from a neurological standpoint, which pain is a negative emotion in the brain, and chronic emotions and chronic pain are pretty much one and the same at that point. Sometimes you can only get so far with emotions. You can only get to the so far with emotional trauma, with physical
Yeah.
trauma. And it's okay to take a nerve that's, I don't know, a few inches long, that's telling that joint it's angry, to ablate it and not feel it. Because at that point, if the joint's moving fine, if you're still seeing your therapists and your chiropractors, and if the disc is fine, that nerve, I don't think there's much of anything you can do to get that nerve to calm down.
Yeah, and what been able to see so far is that there's no clinical evidence that serial or repeating ablations to these nerves, the medial branch nerves, actually causes any kind of clinical negative consequences in the long run. This hasn't been shown as of yet,
Sure.
which is positive. We know that the medial branch does innervate the multifidus muscle, and we do understand that the multifidus muscle can be important, but we haven't seen long-term deleterious effects of denervating that medial branch nerve so far.
Yeah. And when you are when you're denervating anything, you are going to change. So from our end, you're always going to change brain function. In fact, there's a
Yes.
research study out there that the study's name is actually "Cut a Nerve, Change the Brain." And that's exactly what it says. It's incredible. It says, "Cut a nerve, change the brain." You cut the nerve, it's going to change the brain function. But change your brain function with a multifidi that's a little unhappy and a medial branch nerve that's unhappy, or get out of pain and have higher brain function because you're no longer in pain. I'll go with option B.
Yeah, like exactly as you're saying, it really comes down to that patient, that case, that right. If their back pain is so significantly limiting quality of life and function, then yeah, it might be worthwhile to try something like an ablation,
Yeah.
right? So
So then next, let's say that person's not a candidate, but we're still having some disc issues.
yeah, so again, back pain has a host of various diagnoses as far as how I look at it. So, could it be the facet joints? Yes. Could it be the disc? Yes. Could it be maybe the multifidus muscle itself? We understand that as now a possible cause of back pain. We now also understand that the vertebral end plates, or the space between the discs and the vertebral bodies, can be a source of pain. That's relatively recent over the past 5 to 10 years, and there is a new treatment for that. So what I do next is I think, okay, well, again, this is where imaging and history really comes into play. Um, the next treatment is actually very, very similar to ablating the medial branch nerve, but instead of ablating the medial branch nerve, we ablate the basivertebral nerve, and that nerve sits in the center of the vertebral body, and that receives pain signals from essentially inflammation around the end plate, which again, the end plate is the interface between a disc and the vertebral body itself. Um, so it's exactly the same technology. We still ablate, it still gets to a certain degrees of temperature for a minute and a half to 2 minutes. But instead of at the medial branch location, we go directly through the pedicles into the vertebral body. So it sounds a little bit more invasive, um, but it can be done safely, and a lot of insurance companies are actually covering this procedure now. So that's another treatment for low back pain, typically anterior column. So by that I mean patients who have a strong history suggestive of flexion based pain. So their sitting causes pain, bending forward causes pain, prolonged car rides or long periods of sitting, and they actually feel a little bit better standing up and moving around. It's really just loading the spine and bending forward, suggesting anterior column overpressuring. That then makes me think, okay, maybe this is a more vertebral end plate type pain. So, and then if that is the case, we get the MRI, and actually modic end plate changes are changes that radiologists will actually comment on, and we can actually see those on MRI. So now we have like an objective way to measure whether or not someone might have back pain due to that source, which is really exciting because we, for a long time, just thought modic end plate changes were kind of noise in the
Hmm.
background of arthritic changes of the spine. So,
Yeah.
so that's one, and then the other one I really want to mention, which is really really great, is multifidus um, multifidus associated pain. So the idea is that the multifidus muscle is not working properly, and therefore it needs to have some source of restoration or some therapy in a way, some rehabilitation. That's the word, rehab. And so now, and I've yet to find a physical therapist who can actually help a patient physically rehabilitate the multifidus muscle, but there is now a therapy where we can stimulate instead of ablate the medial branch at the L2 vertebral or the L3 vertebral body and actually activate the multifidus all the way from the L3 vertebral body to the sacrum. And basically, it is a targeted form of physical therapy where the patient activates this device twice a day for half an hour and they actually feel deep contractions in their back. And basically, over time, they realize that they're doing more, they're walking more, they're functioning, they're performing their daily activities of daily living, and their pain starts to subside. This is not a treatment that occurs overnight, as you can imagine. It takes twice a day, daily activations of this muscle. And the data we have out right now suggests that around 90 to 120 days, that patients really start noticing a big difference. So if you think about it, if you're trying to strengthen a muscle, build a muscle, you're not going to see gains overnight. This is something that you have to work at repeatedly and gradually over time, which I'm sure aligns with a lot of your treatments too.
Yeah.
um, you gradually see the changes and the functional benefit over time. But the cool thing about this treatment is that we're actually getting to the source of the problem. We're not just putting band-aids on the problem and
Yeah.
covering up the problem. We're actually getting right to the solution. And the nice part is patients don't need surgery for that.
Huh. And just like a like metaphorical, I guess not metaphorical situation, but kind of like I guess a real time situation is people will have arthritis. They might have disc space narrowing. So those discs are flattening out as we can see on MRI. And if they go into a orthopedic surgeon or a spine surgeon of sorts, they'll say you're due for surgery. Are all of these potential options for these people as well?
So potentially, yes, yes. In fact, the medical system, which I'm using the term uh, we have, I think, treated the disc a little unfairly over time because we haven't had other aspects of the spine to blame for pain. And so discogenic disease is always a term that we've used for so long, but we haven't really had great treatments for disc pain.
Hmm.
It's also very difficult to diagnose someone with specifically disc pain. And so a lot of times I'll see these patients too where they come in, they'll have one really highly desiccated disc, L5S1 for example, and they will say, "Well, this surgeon told me that I need surgery, I need a disc replacement." Um, and we'll say, "Okay, well, I wanted to go to pain management to see what other options exist." And I'll take a look at their MRI and I'll say, "Well, okay, well, you have just low back pain. You don't have any radicular symptoms and you don't have a big disc herniation. um, we could try an epidural, see how that goes. We could try the medial branch and radiofrequency ablation, see how that goes. And then if they have modic end plate changes or they have multifidus dysfunction, this gives them so many other options rather than just going in and replacing a disc.
Yeah.
Because I've even seen those patients. Of course, I'm biased because I'm a pain doctor, so I see all the docs or I see all the patients who say go to a surgeon are not better, and then they come to my office, right?
Yeah.
So there are plenty of folks who do benefit from surgeries as well, but again, much more difficult to diagnose just discogenic etiology related pain. And now in today's world, we have so many other options for these folks. So that's
Yeah.
it's a good time to be in pain, unfortunately, but
Yeah.
it just means that there's more opportunity for folks these days. So
So Nick's given us a countdown, albeit he's given us a countdown for being 10 minutes in advance of your hard out. What other technologies do you want to go over?
yeah, I'd say Probably one of the most common ones that we'll use is something called neuromodulation. So just think of the nervous system and we're modulating it. So, how do we do that exactly? Well, we don't do that with medications, we do it with stimulation. So, what does that mean? So, stimulation is just using small electrical impulses, kind of like a TENS unit, to essentially change how neurons are firing to each other. So, for example, patients who have back surgery, they'll come to my office and they'll say, now I can, my numbness is better, or I don't have any tingling sensations in my leg, but I still have this really severe leg pain after the surgery. And now there's evidence suggesting that instead of having a repeat surgery, unless there's something structurally going on in the spine, so of course we'll want to get updated images and et cetera. But spinal cord stimulation is um, the probably number one thing we do for a case like that. So what does that mean? So essentially we put these small wires into the spine, just in the epidural space. So instead of a steroid, think of the wires going in, and patients can actually try this out for a week. And they go home, they live with it, they see if it helps take care of that nerve pain that they're having in their leg. And then if it does help, everything comes out after the 7-day trial. We can go back and putting in a more permanent basis where everything goes under the skin. And so that's the other technology that I think that has become a lot more effective for nerve pain per se lately.
And when I think nerve stimulator, I've seen like almost like fanny pack size things that I've seen in patients in the past. Are they like those anymore?
No, fortunately, they've yeah, they've become much smaller now. They also don't need as much recharging as they used to in the past. So oftentimes we would joke about how patients would have to plug in,
Yeah.
at night, and obviously this is via Bluetooth, but still they would have to have a fanny pack and have something on them right over the area to recharge their battery. But now technology is so much better, and the MRI conditionality is great too. And what I mean by that is they can have these devices and have MRIs and not have to worry about their device being incompatible or things like that. So all these concerns that we had issues with before, there are some caveats in different circumstances where it still applies, but a lot of the companies have really improved their technology.
Gee. All right. You want to squeeze in anything else?
Yeah, I think we got to do 5 more minutes. It's fine.
Okay.
Um, yeah, I would say in general, if you want to have surgery because you believe that there's a fix, I'd say there may not be a fix that at least our modern surgical techniques um, can address. I would also say, in general, if I was treating someone like a family member, that I would always use the least invasive option first. So there might be a least invasive option for you, that does not require general anesthesia or does not require several hours of open spine surgery. So, if that is something that appeals to you, then I think pain management, especially among the newly trained physicians, I think there might be a really good solution for you these days. So, um, yeah, that's what I'll say. I know if I'm we're all getting older, so when I become older and to the point where I'm dealing, maybe I'll have these issues one day. I know I'm gonna go to pain management first,
Sure.
because I might not need surgery, unless there's, of course, situations where if, I lose bowel and bladder control, or I have frank weakness in a leg and I can't move, or my pain is so bad that I can't even sleep or function at all, then there are, of course, times where surgery is appropriate and necessary. But if it's just pain, then yeah, I'm just really excited about having all these tools, and then I'm sure new tools in the future will arise for pain. So
Cool. All right. Well, I guess we could wrap up now. Anything else you want to talk about you guys are doing over there or
yeah, I'd say the other new kid on the block is something called peripheral nerve stimulation. It is very similar to spinal cord stimulation, and that we still use the same leads and stimulate nerves, but we don't have to be in the spinal column itself. We can be in the knee. So we can stimulate genicular nerves of the knee. We could stimulate the suprascapular nerve for the shoulder. We can stimulate the cluneal nerve on the low back and flank area. We can stimulate intercostal nerves. So the path and possibilities are pretty much endless at this point. Now, getting insurance to cover these issues and treatments is a different story, which we don't have to talk about today. But it is a growing field that I'm really excited about as well. So there are going to be other options, and hopefully, we'll see coverage expand for joint issues that we'll treat by manipulating the nerves to the joints.
Yeah, and to your point, going back to a show we had, and I think I even mentioned to you when we first met, Dr. David Hansen, a retired spine surgeon. He said particularly spine surgeries had a success rate of 19%. And like that was the beginning of the end of his career. He's like, this is not good.
Yeah,
Um, and this isn't anything against those surgeons because you're talking about people. There's a lot of liability when you cut into a body, and I know surgeons are trained and they want to do what they want to do, but you're not just going to go in there and do a surgery just to do it.
no,
That's not how a surgeon thinks. If they really think they can help someone, they're going to do it.
yeah,
They
agreed,
don't want to have their reputation spoiled. They don't want to have lawsuits, all that jazz. So
agreed.
to your point of having insurance cover it more, it's hopefully it starts coming around in that regard because I'd assume that like you said, surgery is not really going to be changing so much
Yeah, yeah.
as fast as these technologies can really speed up.
Yeah, and where we're kind of headed right now, which is I'm really excited about, is we're in this place where spine surgery and interventional pain are starting to overlap and blend a little bit because of all these new minimally invasive treatments that are coming out. So as you'll see, and same has happened with the interventional cardiologists and the cardiac surgeons, is that they've taken more and more ability to do what the cardiac surgeon did, but in a uh, s- uh, much more least invasive, minimally invasive manner, and as a result, reduce risk and improve outcomes.
Yeah.
So that's kind of where we're at too. Is we're showing that, hey, we have these other procedures that we can do to minimize your pain, improve your quality of life, improve your function. And if surgery is still an option at the end of the day, and we've run through our gamut of treatment tools, then by all means, maybe you need to elect to have surgery, and that's okay. There is always going to be a patient who fails all my treatments. Like
Yeah.
I'm always going to find those folks. But just like surgeons, they're going to find those folks where they don't feel comfortable going because they know they're not going to get a great outcome. So we all have our limits, right? And we all do our best for our patients, but we need each other. We need to collaborate. We need to understand when to refer, when to continue to treat, when to say, you know what, I don't think I can help you. I think you need to see a surgeon. I think you need to see a chiropractor. Well, you know what? Yeah, I would really see pain management first. That's where I think we can find the right fit for the patient. But I think we need to be humble and realize that we're limited.
Yeah. Love it. Well, all right. I guess we'll cut it off because we got to get you back to the office and then we got to go watch that solar eclipse.
Yes. Yeah.
uh,
Very, very important.
well, thank you for coming on. And I guess where can people find you? Where can they find where you practice and all that good stuff?
Yeah. Yeah. So if you Google Kansas Pain Management, our website will come up. And on the About Us page, I have a profile. You can even book an appointment online. You don't necessarily need a referral. You can literally just book it right on the website. And so it's pretty straightforward. But yeah, that's pretty much it. Again, I'm trying to build this presence in Lee Summit. That's going well so far. But yeah, like before, Overland Park. I'm actually in Lawrence occasionally as well, and then Ottawa occasionally. So I'm kind of all over the place. But
Yeah.
so listeners out there, you'll be able to find me somewhere.
Cool. All right. Well, all right, everyone. Thanks for listening in. And as always, we'll see you guys next time.